mind if I say, well,
Hello, I'm Sharon Glaze, and I've been asked to come speak to you about radiation safety. So my goal for today is not to bore you to death, because everyone hates it, but to try to give you some information that'll keep you healthy during your life and also keep you out of court in terms of dealing with your patients. So in the United States, over the past several years, there's been great concern about radiation exposure from medical uses. And actually, the radiation exposures are the highest in cardiology, neuroradiology, and in nuclear cardiology. So you fall right into the category that needs to have some basic information about this subject. So in the early 80s, the studies indicated that medical only comprised about 15% of the exposure to the general population in the United States, and the rest came from background radiation in the earth and radon in the walls of the building materials in your home. But 26 years later, the study showed that nearly half the exposure of the general population is from medical. And actually, the effective dose per individual in the population has doubled. And so this certainly is a concern to those who are interested in radiation exposure to the population. And when we look how the breakdown of this falls, still the largest part is from background radiation, but then the next largest chunk of the pie is from CT, and then nuclear medicine. And because the doses for nuclear cardiology are higher, they are a large part of this little piece of the pie. And actually, CT gets a bad rap because, you know, everybody going to the ER gets a CT nearly. And actually, CT has saved a lot of lives and keeps a lot of people from having to have exploratory surgery, because that's what they did before we had CT. And so it's perhaps being misused in some situations, but it's a really important tool for us, and we certainly can't do without it. So I haven't learned to work this gadget. So we're going to go over these subjects, some of the units and limits, because you have to have some small basic understanding of that. And then we're going to talk about how to protect yourself and your patients, and talk about sentinel events, radiation overdoses, and what we're doing here at Methodist. And then I'm going to talk about a law that was passed in Texas, but they've postponed indefinitely, just so you have some basic knowledge of it. So the units of radiation exposure are the Roentgen, or now in some cases it's called air kerma. And these are posted on all your cath lab units, because I'm the radiation safety officer here at Methodist for all the x-ray equipment here and at Sugar Land and Willowbrook and West. And also, I take care of all the interventional equipment. And so I guess through my career, I've done about 1,000 cath labs. So I may look like your grandmother, but I'm pretty into interventional fluoroscopy. And so I'm kind of an unusual person. The second unit is the unit of absorbed dose. And so that would be the dose to some organ or to the skin, in your case, if you've ever irradiated a patient. And the new SI unit is the gray. And so we're all trying, where we grew up with liters and grams, we didn't grow up with grays. And so mentally, I'm still trying to make the conversion. And the unit for your radiation exposure is the rem or the sievert. Here at Methodist and in most hospitals, we're still working with rem and millirem. A new and important unit is the unit of effective dose. And it's basically, if you irradiate my heart, what is the detriment to my whole body from having irradiated a small part of it? And so this is important in terms of risk. And if you do research, everything you do, you'll have to express what the effective dose was from that activity. And it basically sums the tissue weighting factors and helps determine the detriment equivalent from the same whole body exposure, as I said. And the unit is the sievert. And here's an example of some of the weighting factors, but if you ever need them, you can easily get them over the internet. And so this is the difference. It's a factor of 100 difference between a gray and a red. And so my brain's working on that. In terms of personnel protection, every year we provide you monitors. They're supposed to be Warnich or collar, which stabs you right in the neck while you're trying to cath. But they put them at the collar because this is the unprotected part of your body, your head. And it also is used to calculate the dose to the lens of your eye because heads are about the same size and they apply a correction factor and estimate the dose to the lens of your eye. So the limits have not changed for the whole body in the 40 years I've been doing this. And so it's 5,000 millirem. Who are the only people in the hospital that approach this value? Cardiologists. So you need to wear your badge so you can learn what you're getting and monitor how you change your behaviors, how you can reduce your dose. The lens of the eye dose has changed. They decided the lens was less radiosensitive than they used to think it was. And it's now 15,000 millirem or 15 rem. And then the thyroid, the skin, and extremity limits are 50 rem per year, or 50,000 millirem. There are other dose limits. Pregnant workers are limited to 500 millirem during the gestation because the fetus isn't a radiation worker. And so they didn't sign on for this, and so we have to monitor them very carefully. And then members of the public, we have to limit their exposure to 100 millirem per year or 2 millirem in an hour. And sometimes this can be a challenge. One example of that is pet facilities. That can be a challenge because at 511 keV, the exposure rates can be high and it takes a fair amount of shielding. So where does your radiation exposure come from? Well, when we use the primary beam, the pointer doesn't work on this blackboard very well. When we use the primary beam to create the image, it interacts with the patient and produces scatter radiation that is of a much lower level, but nevertheless it's proportional to the entrance exposure to the patient. So here's an important concept. Anything you can do to reduce your patient's exposure is also going to reduce your exposure. So it's important that we use the lowest dose equipment we can for both of you, your patient and you, and do other things we can do to reduce the exposure rates. So the basic principles of radiation protection are the same whether we're dealing with something that's been attacked with a dirty bomb or a cath lab or a nuclear reactor. It's time distance shielding. And so in terms of time, there's a little more of a sermon for you because you control the fluoroscopic time. So it's important to try to learn to limit your fluoro time. I catch myself all the time. Here you're managing the medical aspect of the patient. You're trying to do a tedious, delicate little thing and think about what's coming next. Catch myself all the time with my foot still on the pedal when I'm not doing anything. And so you have to train yourself starting in the beginning to watch what you're doing in terms of how long your foot's on the pedal. And so maybe, just hearing me say this will help you think about that during your career. Then it's important that you limit the time you're adjacent to the patient, because that's your source of exposure, not that evil x-ray machine. It's the patient that's exposing you because of the scatter radiation they're producing. And so radiation follows the inverse square law. So this is the patient, and I'm a foot from the patient. If I can step back another foot, I've doubled my distance, and my exposure rate's down to a fourth of what it was when I was standing next to the patient. So one little foot makes a whole big difference in cutting your exposure rate. So, obviously, but I stuck this slide in. So everybody thinks I'm doing a lot of fluoro. That's the biggest problem here in the room. But actually, the biggest problem is the digital acquisitions, because the X-ray unit runs at 5 to 10 times the exposure rate during a digital acquisition that it does during fluoroscopy. So it's kind of important. I know you're trying to hold the catheter still in whatever you're doing, but if you can somehow step back during your digital runs, it'll really cut your exposure rates down a lot, because they run really seriously 5 to 10 times higher during digital runs. And then we provide protective apparel to you. And you need to learn to use your table shields. So here's an example of this one. It's nice with the pull-down shield when you can use it. Some facilities have a lead drape, and that helps keep the scatter from coming under the shield at you. Unfortunately, ours don't, but you have to remember it's not just hanging up here in front of your face. You need it between you and the patient to have it do any good. And this little gadget is really important, these table shields. I hate those things. When I go to test a room, the first thing I do is try to move them out of the way. But you guys can't do that, because they did a study of cardiologists, and most of them had no hair on their legs by the time they were like, I don't know how old, 50 years old. And they had epilated the hair on all their legs. And that's when they started putting these table shields in. So if we had women here, I could say, well, you won't need laser hair removal if you don't use your leg shields. So I'm really serious. You need to learn how to use these, because the problem is the X-ray tube's under the table, and the primary scatter hits the table and the patient and bounces right back at you. So those leg shields that are so annoying are really important. So try to keep learning to use those and to work with them. Fortunately, you work from the groin, so you're a little bit further back than I am when I'm fooling with these machines. Yes.
Are there certain views in which there is more scatter? So I hear that PA, there's less scatter when the tube is straight up and down.
I'm going to have a little slide to show you. It may be coming up shortly.
It's not advancing?
Yeah. I must have.
Oh, you turned it off.
Okay.
She's not pregnant.
So in the cath lab, we try to, we do have only 0.5 millimeter lead equivalent material. Actually, in the whole house, we have only 0.5 millimeter. They make thinner lead equivalent materials, but we try to provide you the best. However, we also provide lightweight materials, which are they're very proprietary. They're little recipes all their own, made of high Z materials like copper and bismuth and zinc and different things to be lighter weight than actual lead. And they often have a lead mix in as well. And so we provide those to you. I need to make you aware of a couple of things, which is the backs are usually 1/4 millimeter. And if you have a wraparound thing, it's usually 1/4 millimeter on each side. So if it doesn't fit you properly and doesn't wrap around correctly, you're getting like a strip of 0.5 millimeter and then 2 sides of 1/4 millimeter. So you really need to have an apron that fits you correctly so that you've got the whole wraparound lead equivalency. And you need to, we're trying to make you the radiation safety people in the room. And if you see nurses, because I see it a lot of large busted nurses, the thing doesn't quite fit them correctly. And so when you have your own practice, you need to make sure that, your people are outfitted correctly. Lead's very soft and tears easily. It needs to be hung on proper racks. If you don't take care of it, it won't take care of you. And let's see, what else can we talk about? There are some things called radiation-resistant surgical gloves. Have you ever seen them?
Nope.
The pain medicine people are really into them. Somebody teaches them they ought to be using them. But they actually are only 20% protective. That's why they can't be called protective. They're called resistant. And they're really a problem because these X-ray systems have sophisticated automatic brightness systems on them. So when you move from the chest to the thick abdomen, they adjust the rate so you can see what you're doing. And when they see these low protective lead gloves or radiation-resistant gloves, they shoot the dose rate up really high, and they're only protecting 20%, so your hands are really getting irradiated more. So don't let people talk you into trying those gloves. They're not a good idea. Okay. here's the answer to your question. There isn't much you can do about it, but when the unit's straight up and down, if you see this darker shading, it's kind of down in your apron and in your chest in a protected area. But when you have to angle the unit, then it comes more up towards your face. But if you're using that pull-down face shield, then that helps protect you from that. But yes, the scatter rates are higher when it's angled.
So another question, sorry. Is the patient exposure also higher? Because, I recently was told, this patient had one long procedure where they used a lot of angulated shots, and the radiation dose at the end of the case that's measured was a lot higher. And the explanation that was given to me was, that because of the fact that they use a lot of angulated shots, the patient dose was higher. Now, does that...
So I suppose so. If you're using some big angle and it's going through a thick tissue amount, then it's going to have to run the rate up to penetrate that. So
does the machine...
Since I don't go to the procedures, I don't see these, but it's conceivable that what you're saying is true.
So I'm not sure if this is a question that you can answer, but the machines, are they programmed to run in a way where if it's a heavy patient, for example, or it's an angulated shot and there's less reaching the eye, does the output automatically increase to compensate?
Yes.
It does.
I don't know exactly in the modern equipment how they do it, but in the older days they used to have like photomultipliers that sensed how much light they were getting, and they'd raise the rate to adjust for it. We have different methods with the digital equipment, but the answer is yes. It definitely adjusts the rate, and actually the tech probably does it for you, but there's some choices of small, medium, average, and so it'll start at a higher rate with the large. So, okay, this is kind of blurry, but intuitively this isn't going to seem right to you, but in a lateral orientation, in the cath lab you usually do them at 45 degrees under the table, so this is more like applicable to neuro, but you should stand on the side of the image receptor. Why? Well, the reason is it's kind of like the tube under the table with your legs thing. We check very carefully to make sure the beam's collimated correctly. Now, if the beam weren't collimated correctly and you were getting primary beam, then that wouldn't be good. How can you control that? You can have the tech bring the shutters in so you can see them on the screen. And if you see these little square shutters, you'll know there's never any primary beam going outside the detector. And here on the X-ray tube side, you're getting the primary scatter back in your face. So it's better to be on the other side, but to collimate in so that you know that some physicists like me didn't make a mistake and that the shutters are really there. So a lot of them are irises and you can have it brought in. So to me, this is the kind of information you guys need to know, and so I hope it's helpful. Physician errors.
We don't make any.
How many times have you left your hands in the beam because you didn't want something to move? Chosen expediency over personal safety. Had your backs to the X-ray source. Been unaware of your foot on the pedal, that's my big sin, and pushed away a protective barrier. So, you need to think about what you're doing because this is your whole life. I do like to see you wear wraparound aprons. A good example is we had one surgeon out in Sugar Land who told me his lead apron wasn't working. And so he was doing a research project and he was getting readings on a badge under his apron. And so I didn't have time to go out and fool with this, so I told the tech to put a wraparound apron on him. And even though he thought he wasn't turning enough to get the beam hitting him on the side under the apron, apparently he was, because putting the wraparound apron on him got rid of all the exposure under his apron. So with the type work you're doing, I do recommend wraparound aprons, because then you don't have to think about, am I turning my side too much or anything? You're just protected. So I do recommend those. Staff protection, yes.
Pardon me, how effective is the lead in the first place? Like if you were to irradiate directly, does it reflect 99%
okay, so
or
first of
90%?
all, you're not getting primary beam to that lead. It's made to protect you from scatter. So if I shoot an X-ray beam directly at it, I might get a different number, but it actually protects you from about 95 to 98% of the scatter radiation. So they do a really good job. And so staff protection, it's kind of important, since you're the leader in the room, to pay attention to what you're asking your staff to do. So one example is one time, one of the techs said, oh, I have my back to the beam most of the time. So we put a badge on her back and discovered that the way the doctor had her positioned, she was picking up about a rim a month to her back. Now, she had on a wraparound apron and a thyroid shield, but still, he didn't have her positioned in the right place to adequately protect her. So you need to be aware that someday you're going to be responsible for all this staff that's working for you. Patient protection. In the early 90s, about the time stents started being really effective and used a lot, patients started showing up in the ER with these type of lesions. And basically, they're all coming out of cath labs. And there were all kinds of workshops, and basically they determined that these were the type cases that were causing them: angioplasties, actually embolizations, and some TIPS procedures and other things, but mostly out of the cath labs. And so I have some gory pictures to show you. They required plastic surgery. And what are the dose levels associated with these injuries? Well, I brought that for you to take home with you as sort of a take home, just as a reference. Hopefully you'll never need to know this kind of information, but can you pass some of these? The main thing, so some of these gory things you've seen are like secondary ulcerations, so they received about 20 gray for that. And I wanted you, though, to notice that these don't always show up immediately. Some of them take 6 weeks, some take a whole year to show up. So as you see your patient from time to time, you could review their back and see how it's looking. You also have to be sort of aware of your patient's previous radiation exposure. The classic example is they were at hospital X down the street and had an angioplasty 2 weeks ago, and now here they are on your table. And so you need to put some thought into that, because that sort of limits your time of how much fluoroscopy and digital runs you should use. And this is a great one. If something doesn't seem right, you need to stop and investigate, because this one happened right here in Houston, and it actually was in an EP lab. And the doctor thought the image looked really crummy because he thought he saw arm bones in his picture, but that couldn't be possible, right? Well, there was a rad tech in the room. They should have known, and nurses should have thought something, but this person's arm was laying on the lateral collimator. When they had it like this under the table, somehow the table was scooted over enough that their arm was laying on the lateral collimator of the X-ray tube. So I saw the picture of it after plastic surgery, and it didn't look that good either. So, okay, Joint Commission came around in 2005 and defined a sentinel event as prolonged fluoroscopy with cumulative dose greater than 1,500 rads to a single field. So all the time we have to watch for sentinel events, because even though we're DNB, they follow this policy from the Joint Commission. So we also, I should stop and say that the government decided to do something about this, and in 2006 they passed X-ray regs that do several things. One of them is provide information to you guys as to where you are in the patient's dose situation and what the rate is. And so you know how much time, you can know how much fluoro time you put in and what the cumulative milligray is. And each one of our units has this. They're displayed on the monitor, or in Cath Lab 9, it's above the monitor. And they give you the units in microgray per meter squared, and then also in total milligray. We don't make much use of this because it's not very useful information. So this just kind of helps me get my head straight. It's like liters, 5,000 milligrays, 5 gray, and then because they're off by a unit of 100, it's 500 rads. Why have DAT meters in the past been so difficult to use? Well, the reason is because they read out in dose per area and dose area product, and you have to know the area on the patient's back to get much information out of it. Where is the point of patient dose calculation for these units? So the way they've decided to do this is they're assuming that this isn't your standard 23 cm patient. They're basically saying it's about a 30 cm patient. And so they're calculating back half the distance, 15 cm. So if you put an ISO center at the point of interest and then measure back 15 centimeters, that's what they're calling the interventional reference point. And that's where these DAP meters are displaying the information to. So if you ask me what is the dose to my patient, sophisticated new machines vary all of these parameters to give you a great image. They vary the kV, the MA, the pulse width of the MA, the copper filtration, they pull it in and out as needed. And I couldn't guess to save my life what your dose rate is. We've taken standard anthropomorphic phantoms in, and the census on your unit prints out how much the technique used was. and I can't reproduce it to save my life. So what we're doing is basically using the milligray reading the machine gives us. How can patient dose be reduced? Well, the machines now do it for you. They increase the half value layer, which is basically by adding copper filtration to limit the skin dose and use higher energy to penetrate to the image receptor. They use a higher kV because it penetrates better. They set a minimum kV so that it doesn't go too low and just dose the skin. And they try to lower the MA. The new machines we have really have a lot of promise for the future. The Artist Q and even more the QZen have all these features plus other clever dose savings things that have been added to these units. And I think they're going to have a very, very bright future here at Methodist, helping us keep patient doses low and your dose lower. It's important to use as little magnification as you can because the dose goes up with the magnification. And it's important to keep the flat panel as close to the patient as you can without ruining your sterile field. That way the automatic brightness system doesn't have to drive so much. And we use pulse fluoro all the time. You don't have to select it. It's automatically selected. And it's important to keep, just like inverse square law helps you, it hurts the patient. If you accidentally, like here it's one dose unit because the patient's far away from the x-ray tube. Here's more like your situation and it's more, but it's still acceptable. But if you get them too close to the x-ray tube. Now, I don't worry much about this in the cath labs because in order to angle the tube, you have to have it sort of mediated. I worry about it with C-arms and surgery because they don't swing them so much. Okay, I want to talk about field overlap. So part of the problem is you go LAO and you go RAO, and you're hoping that this is what's happening on the patient's back, that the fields are totally separated. But in reality, that's not the case. It's more like this, and you can kind of see that they're overlapped. And this is because the tech comes through and recenters up the center of the field to let you see what's going on more appropriately. And we're almost through. Pulse fluoro requires careful inspection because you would think if you're running continuous and it were 4 hours per minute, if you cut it in half, it should go down to 2 and then down to 1 and so forth. But in the beginning, they can actually alter the pulse widths to give you better image quality. And so in the beginning of pulse fluoroscopy, I had the experience of going in, and it was all the same no matter how much they were pulsing it because they had widened the pulse width. So this doesn't tend to happen anymore. Okay, as far as dose goes, Houston Methodist has some guidelines, and at the end of the case, if the total dose is greater than 500 rads or 5,000 milligray, a PSN is filed. And if it reaches 1,000 rads or 10,000 milligray, then I have to go, or one of my associates goes, and we will try to decide if this was high enough to be 1,500 and could it be a sentinel event. Okay, I'm going to read you 2 or 3 little things and then we're done. So the only irradiated population is still Hiroshima and Nagasaki from World War II. There's some cases of like early radiologists, but the only whole body irradiated group are these people, and they reassess their information all the time. And the report is actually the Beer 7 report, I believe.
Friday morning.
The Beer 7 report. And so I want to read this to you. In Beer 7, the cancer mortality risks for females are 37.5% higher. The risks for all solid tumors like lung, breast, kidney, and liver, and other solid tumors added together almost 50% greater for women than men, though there are a few specific cancers like leukemia, which were higher for men after exposure to radiation. And then we're always concerned if you go into pediatric cardiology, because Beer 7 estimates that the differential risk for children is even greater. For instance, the same radiation in the first year of life for boys produces 3 to 4 times the cancer risk as exposure between ages 20 to 50. Female infants have double the risk as male infants. And I don't know if that's because of breast cancer or what the cause of that is. Okay, the last thing is Texas passed a law which was going to require physician training requirements. And actually, they were requiring a minimum of 8 hours of training in X-ray equipment. And I always thought that was a little excessive. About 1 hour of this and maybe some radiobiology would be about all you guys need to know to protect yourselves and your patients. But actually, and then it included 1 hour extra of unit-specific information. But actually, the Texas Medical Association lobby was very effective because they postponed it indefinitely. And so for people like me, we really think everybody needs a little training, maybe not being tortured with 8 hours, but people need a little training of what to do, and now they've totally negated it. And that's all I have. Thank you.
Thank you.